All right. Good morning, and thank you all for being here. Like you said, I'm Beau. I'm from Madigan Army Medical Center, and we'll be looking at the management of hypothermia in a pig model. We have no financial disclosures and no animal disclosures. All guidelines were followed for management of the animals. So we're all familiar with the lethal triad. This is a concept that's been drilled into us since we were medical students. But for this, we'll focus on hypothermia and its relevance in management in regards to the lethal triad. We've been fortunate over the last several decades that we've been in conflicts that we've had air superiority, and so the transport and evacuation of injured casualties has been relatively easy. There's a possibility, though, however, in the future where that luxury may not exist, and we may have to hold on to patients for hours or even days before we can transport them to definitive surgical intervention until we have safe airways. And so this is something that's particularly relevant as we look forward to future conflicts that our country's involved with, where we may not have that luxury of air superiority. And so we all know hypothermia, of course, it leads to worse outcomes. So even a decrease of the body temperature by 1 degree Celsius results in a decrease in coagulation activity by 10%. And a temperature of 34 degrees Celsius is enough to inhibit clot formation. And there's been several studies published that look at hypothermia as an individual predictor of worse outcomes compared to normothermic patients. However, the pace or the rewarming rate for these patients is something that's still relatively untested. And how does the rate of rewarming impact reperfusion injury and patient outcomes? And so we hypothesized that rapid rewarming would lead to worse patient outcomes, potentially as a result of reperfusion injuries. And so we looked at 30 pigs or 25 pigs after model development. We had 8 that were the control pigs that had no hypothermic conditions. 9 underwent fast rewarming with a Solex intravenous catheter. This is essentially a catheter you put into a large blood vessel, and it has these little rivets and like a cyclone pattern around it where you circulate either warm or cold solution through, and it rapidly warms or cools the patient based on that surface area with the blood. This was compared to our slow rewarming arm, which is a military-issued HPMK, or hypothermia prevention and management kit. It's essentially an insulated shell with a self-heating blanket that activates when exposed to oxygen. So think about like those little pocket hand warmers. It's just a large-scale version of those wrapped into a insulated sleeping bag. We looked at hemodynamics, so this was collected from a Swan-Ganz catheter. We also got basic lab data, TEG data. We looked at cytokine inflammatory markers, and then we looked at tissue histology at several points. So our timeline looked like this, where we had the pigs intubated, lines were all placed. We got kind of baseline lab values at that point. We then bled off 35% of their blood volume, and this was collected for transfusion later, but this was enough to induce hemorrhagic shock. We then induced hypothermia down to 32 degrees Celsius. Pigs then sat at that temperature for an hour, so an hour of a hemorrhagic shock with hypothermia. We then collected repeat lab data, tissue data, and then we auto-transfused. We gave them all their blood volume back, so back to normotension, and then we started the rewarming process. And this was a 2-hour process. The fast rewarming oftentimes reached euthermia or normothermia before that 2-hour period elapsed, and so we called that. So once they reached normothermia, then that was it. The HPMK group oftentimes would not reach normothermia, and so after 2 hours, that was the end of the rewarming period. We again collected tissue and lab data, and then for an hour, after an hour, they went damage control or modified damage control surgery, and this could include laparotomy, thoracotomy, splenectomy, bowel resection, that sort of thing. And then we got final lab data. So looking here at our results, looking specifically at temperature, so the pigs that were rewarmed with the Solex catheter or the rapid rewarming, the mean temperature they reached was 37.9 degrees Celsius, so normothermia, whereas the HPMK, after 2 hours, the mean temperature was only 34 degrees Celsius, so still hypothermic. And then pigs that underwent hypothermia had worse degrees of hypotension based on their MAPS and worse bradycardia. We did not see any difference in their acidosis. Similarly, we didn't see any difference in lactate or other lab data. There was no difference in mortality between the two groups. And then looking at the coagulation, there was no difference in the coagulation factors or TEGs based on the hypothermic data or the control. And then the one difference we did see with pathology was the expression of IL-1RN, which is essentially it's anti-IL-1, so it's got anti-inflammatory properties. It blocks IL-1, so it blocks the inflammation caused by IL-1. We saw that this was lower in the slow rewarming group, but we did not see any difference in the histology of the skeletal muscle or liver tissue. So in discussion, this study sought to evaluate the effects of rewarming rates in an in vivo porcine model of trauma. Hypothermia was associated with more severe shock compared to the normothermic model. It was also associated with slower heart rate, which is consistent with the data about the cardioprotective effects of hypothermia. Rates of rewarming did not affect cellular processes based on lab data. We did not see worse reperfusion injury between the pigs that were rewarmed slowly or rapidly. We did notice that IL-1RN was higher in the slow rewarming group, so that means in theory, I guess, less inflammation in the slow rewarming group. And this suggests that more time in a hypothermic state was correlated with an inhibition of inflammatory signaling. We did not see any changes in other inflammatory markers, and similarly, no difference in the tissue histology. So no obvious, under the microscope, no evidence of tissue damage that was worsened by rewarming. So our results represent a translational model that indicates rewarming can occur at a fast rate and still be safe without risking injury on either a cellular or hemodynamic level. Extrapolating these results to the modern trauma bay, this kind of supports the idea that you should rewarm patients as quickly as possible. So when you get these trauma patients, they're in hypothermia, rather than worrying about rewarming them too quickly and causing a reperfusion injury, this suggests that you should rewarm them as quickly as possible, and if you have invasive means at your disposal, you should use those if that means that the patient is warmer quicker. In conclusion, this is a large animal model of traumatic hemorrhage that supports the use of rapid rewarming as both effective and safe for reversing hypothermia in the immediate post-injury period. Of course, we didn't have long-term data. This is not a survival study for these pigs, so we don't have long-term outcomes for these pigs. And similarly, this is a pig study, so the physiology of a pig is not exactly identical to that of a human. We do know that pigs have a remarkable ability to coagulate, and so this could explain the lack of coagulation differences that we saw. And so certainly, you can't generalize this to humans. It's just suggestive that this may be, rapid rewarming may be a feasible option, and further data needs to be done to look at human rewarming. And that is all I've got. Thank you for your time. If you have any questions, I'd be happy to answer them.